Hello and welcome. My name is Mitch Sanders. I'm here with Jordan Yaron today, and we have a very special guest. She is Lisa Gould. Lisa is the just an amazing person, but also won the Wound Healing Society Lifetime Achievement Award this past spring in 2024. Lisa, welcome.
Thank you, Mitch. It was such an honor to be voted by your peers and people that I respect. It floored me. It was really a great honor to win that Lifetime Achievement Award.
Anyone who spends 10 years on the Wound Healing Society board probably deserves three of these awards. So, no, but for the audience, I know Jordan is a cold, so he's not speaking, but could you provide kind of your lifelong journey of even you talked about your parents when we were at SAWC. I think we talked about tapestries. I'm trying to remember.
I grew up making draperies.
Draperies.
Yeah.
Okay. Could you
So
bring
I
us
grew up
through your
sewing.
lifelong journey to become a wound care doctor and an amazing scientist?
Well, thanks. Yeah. So, my parents were very supportive of anything that I did. They always said to my sister and I, if you do something and you do it well, you better continue to do it well. So, but they didn't dictate what we would do. I just had kind of an interest in science. I tried lots of things. And it was funny because in high school, everybody was saying they were going to be a doctor, and I was like, I don't think so, but maybe I will. And out of all those people, I'm one of the few that actually did do that. So I was actually a Russian major. I was a Russian and chemistry double major in college. I originally said I was going to be a chemist, but I didn't really fly that way. You needed either Russian or German. So I took Russian and I loved Russian. And so I actually was thinking of being a spy. But at that time, it was the Soviet Union and things were pretty quiet. And I said, it's going to be kind of boring. So maybe I'll go to medical school. So I went to Oak Ridge National Lab for a semester when I was in junior year of college. And I really liked that research. It was fun. And so I was sharing, we were poor, so we shared houses and stuff. So these two guys were definitely going to be chemists. And I said, I kind of like this research stuff, but I'm planning to go to medical school. What should I do? And they said, check the MD PhD box. So that's what I did. And I got into the medical scholars program at University of Illinois. And that really did shape me. It was a highly self-motivated program. In those days, they didn't tell you what to do first, how high to jump, or any of that. And so we picked a lab. My project was in Xenopus laevis in the African clawed toad. And I was in direct competition with Brown and Goldstein. So we decided to revamp that project because they were clearly going to get the Nobel Prize and I wasn't. And so I did a developmental biology program looking at a gene in the liver primarily, but we looked at all different parts. And then when I moved on, I said, I need to do something that's more clinically relevant. So I got into the lab at MCV at the Medical College of Virginia with Bob Diegelman and Kel Cohen, and designed some projects that were more clinically relevant. At that time, we were doing fetal wound healing. And again, I thought, well, I'm really not going to be doing fetal surgery, although Yinka Olatoya is. But I didn't see that as my pathway because I wasn't going to be a pediatric surgeon. And I saw all these wounds, and I was like, we need to do something in chronic wounds. And so I set out to understand that better, and designed a flap that I designed that when I was in Milwaukee for my first job, and designed a ischemic flap that would simulate pretty much like a diabetic foot ulcer or somebody that had enough ischemia that they wouldn't heal, but not so much that it was going to die. And that turned out to be good because we could sample the wounds and we could give either systemic or topical treatments. I could do it in diabetic animals. I could do it in aged animals. And although it was a, kind of finicky flap, it turned out to be a good way to sample wounds.
And
And then
that was at the
I,
Medical College of Wisconsin, or where?
yeah,
Okay.
so I went from MCV, Medical College of Virginia, to MCW, Medical
Yeah.
College of Wisconsin. And that gets a little confusing, but that's where I did my hand surgery fellowship and stayed on for a few years.
Neat.
And then I got the call to go to Galveston to actually adopt Marty Robson's old lab. Um, and so that was fun. I got to clean up the lab and found a box of old bones that said "do not touch" or something like that, and carried on with that. But I was starting to feel like I was spending all my days writing grants and weekends, holidays, you name it. Um, and so as I started to look at the future, I said, maybe I'm better as a clinical correlator. I can work with young people who are writing the grants and doing the basic science, and be a better, be an adjunct for them, because you need that clinical correlation in your grants. I can help because I understand the grant writing process and I understand the science, and then I can provide some human samples. So that's pretty much what I'm doing now, is providing wound fluids and insight, especially insight for new companies, as to, is this really going to fly? Is it a good market? That kind of thing. That's fun for me. Um, and my research, I would say my work is a lot in pressure ulcers. I don't really want to be known for pressure ulcers, but there's so little research in it that I'm trying to get companies interested in that, and saying we need to do some studies and get that up and running. So that's kind of my research in a nutshell.
Do you think that's because once you start turning the patients, they get better standard of care, and then the control is looks better than it should, or is it because because of pricing and reimbursement, it's not reimbursed in many cases for the advanced
Well, it would be
camps?
reimbursed if we had clinical trials. I think
Right,
it's because
right.
they're hard, right? So you have the spinal cord population, and then you have older adults, and they're different. So you would have to do something that's probably in the spinal cord population to keep that a relatively homogeneous group, and then something in older adults that would be separate. And then you start getting into the patients are in skilled nursing facilities. It's hard to do research in skilled nursing facilities. And the wounds really are different. That's where I see a problem with our current ICD-10 coding. A stage 4 is not a stage 4. If there's osteomyelitis in the wound, that's not the same. There's a lot of factors that go into it. It's very hard because clinical trials have to be relatively homogeneous. So hopefully, with some real world evidence, we'll be able to get more answers, but we need good data for that.
And why do you think there aren't a lot of trials on hard to heal surgical wounds? Is it too heterogeneous, or is it too hard to enroll?
So, are you talking about a wound that falls apart after surgery when you say a hard to heal surgical wound?
Dehisces or
Yeah. So I have a couple opinions. One, I think they would all heal if they got good wound care. Catch them early. Surgeons don't like to admit that they have a wound, so you don't find them till very late. A couple of things like that. And there's some heterogeneity. So is it an abdominal wound, a leg wound? There's a lot of different surgical wounds, but definitely surgical wounds or surgical site infections are one of the greatest causes for readmission to the hospital, and one of the highest costs. So they do need to be looked at, and maybe come up with a more standardized approach. And now my next soapbox is wound education. And so if we were to educate people early, some of these wounds might not become chronic, and we could get them healed quicker. Um, and then the patients wouldn't have to suffer so much. So that's what we're really working on, hopefully in the next 2 to 5 years, is getting education out to the general practitioner, believe it or not, to the surgeons, to PAs, and even nurses. They don't get training in nursing school about how to take care of wounds. And if you are afraid of something, right? So give me an EKG to read, I might run the other way. Give somebody a wound to look at and they don't know what they're looking at and it's scary, they run the other way. So I get that, but we need to help because there's, 30% of the patients that are admitted to a hospital have a wound. They might not be admitted for the wound, but they have a wound.
I think everyone kind of agrees that the risk of a bad wound is very, very like the overall morbidity and mortality associated with some of these chronic non-healing wounds is so high, but the layperson or just the everyman walking down the street has no idea how bad this can actually be, and that it's so ubiquitous. I think Dr. Kirshner a few years ago gave a presentation at WHS when it was online, and he said something like 1 in 68 adults in the US is dealing with a complex wound of some sort at any given time. And the fact that, obviously this is with diabetic foot ulcers, but we all know the number of like a 30% lifetime, a 30% 5-year survival rate for diabetic foot ulcer amputations. And you ask any of your family members that are not intimately aware of these things, and they're surprised to hear that a wound can be that bad. Mm-hmm. So with respect to the topic of wound education, the practitioners should already be doing some of this work. Is this something that requires more like the anti-smoking campaigns, the advertisements and the commercials? And do we get it into people's homes? That it's not just people that are in the clinic, but it's actually people just sitting and watching TV, and then they're being shown, this is how bad wounds can actually be. Do you think that there's room for that kind of outreach?
Oh, I agree. I think we need public service announcements. We just have to find the avenue and the way to pay for it. At the annual meeting that was in April, we aired a very short video that Dr. Ira Herman and I created together about diabetic foot ulcers, and with a little girl noticing that her grandmother had a stinky foot wound, and got her in to see somebody and got it taken care of, got her diabetes taken care of. And so we're working on that to make a shorter version that is appropriate for the public, the lay public, and figure out a way to get it out there. But how did they do that, right? Wounds don't have that presence that lung cancer does, breast cancer does. People have tried walks for wounds, and it just doesn't really fly. It's not sexy. But we have to find a way to make it out there and get people to notice and get them to know that if they take care of things early, they actually can heal. It doesn't have to be so bad in most cases. But the wounds are a terrible thing, and the brain is a terrible thing too. We like to ignore it, but there's just so many wounds out there, and young people, old people, everybody.
I've been amazed by how the quality of care changes throughout the continuum of care. So you may have a great doctor in the hospital, but by the time you get home, you may not be getting very good care. And it may have to do with also, just the way Medicare is set up. You may not be getting the right services that are needed. It's a tough issue. And then, as I say, in wound care, we have really smart people like you, but then there's a lot of generalists out there that they became wound care people by default, and they really don't know what they really don't study on the latest and greatest things that are happening in wound care, and they're kind of behind the times.
Yeah, no, it's true. I mean, I've made it my career, and there is a big difference between education of the career wound person versus education of the generalist. We do have a project with EWMA now, the European Wound Management Association, working on educating the generalists. They're also aware of it. It's a global problem. It's not just the United States, but our transitions of care are more difficult, I think, than Europe and other places. It's really challenging, and then our skilled nursing facilities are so understaffed, and just poor utilization, and then trying to follow the patient through their journey can be really difficult. They disappear. Even my patients, sometimes I have to figure out how to track them down. But if I've operated on them, I won't let them go until they're healed. So,
I got,
I said in my talk, my goal from the time I meet the patient is to get them healed. I'm not there to care for their wound. I'm there to heal their wound.
it's great. I got roped into helping on the WCCC to rewrite the guidance documents that you worked on in 2006. So
Mhm.
I'm going to be calling you up and asking for a read and
For
a review of
guidance
what
to
we're
the
doing.
guidance.
Yes.
Yeah. Yeah, so that's the FDA version, and it is, they write things so vague, intentionally vague.
It's watered down. We're going to try and make it, which we'd like to make an archetypal. Um, this is what a DFU or a VLU clinical trial should look like, and these are the parameters we want to see. And
Mhm.
I'd love to see kind of harmonization between um, CDRH and CBER and CEDAR because the guidance are different,
Ah,
and
yeah.
and I'd like to also try and harmonize them with what's going on in Europe. So there's going to be some and there's some other, I'd like to bring in quality of life factors and health economics and other, when you're doing these expensive trials, get the most out of the trials that you can.
Yeah, yeah.
But the
FDA will always say they don't do economics, but the economics are important. We have to include them.
if the company is going to be successful and the product is going to heal wounds, you need to show that it's going to give a patient a better quality of life, and there's a real health economic argument for using an expensive product because some of these products are
Mhm.
quite expensive. So
They are.
it's the FDA may not care, but certainly CMS should.
Right,
And
right.
they don't chat much, but somehow we'd like them to understand that these are other important endpoints. And then because of all the advent of the new things of all the digital health solutions that we have and
Mhm.
some new diagnostics that are not so new, some have been around for a while. Um, but we should start helping guide people to use some of these things that will give them more advice around, is the wound truly infected? Because based on visual signs, it's as Dr. Serena will tell everyone, it's like flipping a coin, 50% or,
Right.
25% are clearly infected, 25% are clearly uninfected. The other 50%, it's a coin toss, right?
Yeah. If we could incorporate diagnostics into not only clinical trials, but routine wound care, it would be a game changer. I mean, we know that the diagnostics help people know whether they've debrided enough.
Yeah.
The one, the fluorescent
Molecular,
diagnostic,
yeah.
yeah, molecular, they have shown not an increase in antibiotic use, but better debridement, and then you can get better healing. I mean, I
And
know my
yeah,
surgical solutions, I see so many examples of surgery still does work. I can take the patient to the operating room, I can debride them adequately, get down to good healthy tissue, and then they start to heal. We get, culture guided antibiotics because I'm in there, I wash everything, and then I do the culture, and they get what they need and not more than what they need. And then they can go on to heal. I can do skin grafts and flaps and get them healed faster. And every week I have these examples, which it's what keeps me going. Is that
very
surgery
exciting.
still works, like science, it still works.
I was surprised that the guidance document said don't use enzymatic debriders for clinical trials. For, if you're going to debride a wound,
Hmm.
I think they're recommending sharp debridement. They don't say that, but they say probably don't use an enzyme. It may be, counterindicated for the trial. It may um, challenge. It may be more difficult to understand what happened in the trial, I guess.
Oh, remember that guidance came out in 2006, which means it was started probably in 2002. And it really, that's how slow that
I
organization, that
understand.
agency works. And so it's super outdated. Do
Yeah.
we have more data on enzymatic debridement? I don't know. There's some.
Yeah.
But it does muddy the water as
It's
to what kind of debridement is being done and what you're putting in the wound at the same time.
right. And I saw that a lot of the infection language that's in there that we're going to totally rewrite. It goes back to the old thought of critical colonization,
Right.
and it read, you know, Phil Bullard be proud that it's still kind of mentioned in the guidance documents, but we need to update it to biofilms and update it to, you know, what we could see in a molecular or a diagnostic to better understand what's going on in the wound bed. So,
Right.
so tell me what you're, sorry to get into
No.
the weeds too much. Tell me what fun things you're doing for the rest of the year.
For the rest of the year. Well, I'm actually going to take a vacation in November. That's like a big
Great.
occasion for me. But, you know, I will tell you something that I am most excited about is a change in practice, right? So a lot of people put a matrix on a wound. I'm currently using one that is completely synthetic as a bridge to grafting. I'm learning when it can and can't be used. It does not work well on sacral or truncal wounds because you can't hold it very tight, but it works great in a leg and it helps the granulation tissue grow. I'm pretty sure that the porosity is very similar to the negative pressure wound therapy sponge. And that's why the tissue grows into it, but it's biodegradable. So it
Is
disappears.
this like a MTX or is this a Polynovo thing, or what are you
Yeah,
looking at?
yeah, it's the Polynovo.
We got really good data for their new, I guess they have BTM, the newer one's MTX that doesn't have the top layer.
It doesn't
And
have
we
the
got,
top layer.
yeah,
Yeah.
and we got really good data in a diabetic mouse, and we have a paper pending with Journal of Wound Care on that. But we saw really differences in gene expression of that versus the Integra bilayer product. And we
Yeah.
saw that the cells are gently pushing against this MTX, and it actually accelerates reepithelialization. The data is really impressive with the gene expression, and
Hmm.
the new epithelial layer is just beautiful. So
Interesting.
I hope that paper gets published soon.
So in my humans, the wounds are so big that they won't reepithelialize, easily in our lifetime. But the
Right.
granulation tissue was amazing, and it's also a fifth the cost of the Integra bilayer. So
Yeah.
that was makes it a game changer. And then I'm now using the spray-on cells, the ReCell.
Oh, cool.
And so those two things combined have really changed my practice. I feel so much more comfortable taking care of these really, really large wounds and knowing that I'm going to have a minimal donor site for the patient. Our anticoagulated patients, the older adults, the really sick people, or just huge wounds. So I'm working on a patient right now who had a 20 by 60 centimeter wound. That's pretty big. I didn't really want to give her a donor site that big. So last week I grafted half of it and the other half wasn't quite ready. Friday I'll graft the rest. But when you think about how do you convince an established surgeon to change their practice, those two things in the last year have really changed my practice and actually made it fun. Because
That's
I'm
cool.
looking at how to push the envelope. I love the idea that, especially for the spray-on cells, it's a true find a clinical problem, go back to the bench, work it out, and then bring it out. And Fiona Wood and Marie Stoner did that in Australia over 15 years ago, but it's taken a long time to get to the US, and we're
Yeah.
using it on non-thermal wounds now. It's so cool. And we were
That
waiting
is
for it, and now it's here. So those two things are what I'm doing for the next year. I have a paper on at the American College of Surgeons presenting it, and we submitted the paper for publication because they have one of these early reviews, and one of the reviews says this needs to get out there, and
That's
that was cool. So,
I heard that JWC is trying to expedite reviews for
mm,
advanced cool things.
mhm.
But my paper's been sitting in review as long as the rest of them. So we'll have to see whether I think the people are just busy, you know.
They're
I have,
busy. And so the problem with wound care, though, is it's so fragmented, right? So we have different journals, we have different ways to present. So like the American College of Surgeons, we got the abstract accepted for, it's the surgical forum, but it's a presentation. And then they send out right away that they have a rapid review for
Oh, that's
people
cool.
who've got a podium presentation. So I kind of jumped on it, even though I was like, how am I going to get this done? But we got it done and got it submitted. So I think that's part of the problem with wounds.
Yeah.
Is we need to act as one rather than as all these fragments. But
I've got 3 more papers to review this week.
Well, I get bombarded with them, and I just
No,
can't.
it is.
I
It's
can't
really
review
fun.
them all.
Hey, Jordan, I wanted to congratulate you on your new title.
Thank you. I'm starting my tenure track lab here at ASU this semester. So just waiting for them to give me some lab space so I can get to
That's
work.
exciting.
Yeah.
If you ever want to collaborate, we'd love to. Let us
Absolutely.
know, both
Absolutely.
of you.
Yeah.
So Lisa, thank you for sharing your story with us. We just adore you, and we are so grateful for what you do for the Wound Healing Society. And thank you, kindly. Look forward to seeing this video up online very shortly. Take care, everyone. Thank you. See you. Bye.